various reasons and needed to be replaced. Right? Any other reason? Anyone wants to add something? What does the patient want? So there was a study done a few years back in which patients' expectations from dental implants was studied in a systematical review. So in this study, they found that the patient wants aesthetics and functions. Not just that. If anyone is having trouble understanding my words now, they can open up their captions on their screens, right? There shall be a menu over here, right? So you can turn on the captions from here, and my whatever is my am I speaking will be directly translated to your language, right? You can turn on the captions if anyone wants to, so that will be easier to understand for everyone. Got it? Raise your hand if you understood that. You can turn on the captions. If you are joining from your mobile phone, then the three dots are here. So you can click over that, and from here you can turn on the captions. Okay. So I'm going to continue now. So the patient wants aesthetics and functions, but not just that. Apart from that, they want it quick, they want it simple, they want it painless, they want it long lasting. Most of the time, they want a permanent solution, and all this they want for a reasonable cost. So, what are the traditional method that are available to us? These are the two-piece dental implants, right? So, what is the problem with the two-piece dental implant? Two-piece dental implants are also known as the crestal implant, the Brenmark implant, delayed loading implants, and also the two-piece implant, right? So what are the highlights of these implants? Highlights are these implants are delayed loading, they have a two-piece design, they have a cylindrical morphology. So delayed loading is we have to place the implant, then we have to wait for a healing period of approximately 3 to 6 months. After that, we uncover the implant, place on the abutment, then replace the prosthesis over it. So this is a long process. It takes time. Evolution of the two-piece design. Two-piece design is basically a byproduct of the delayed loading protocol. Because we have to wait for a period of 3 to 6 months, so that necessitated that we make the implant in two pieces instead of one, so that we can attach the abutment later on with this screw, right? So that was the necessary for the delayed loading protocol. Now this connection over here where we join the abutment with the implant, it's the weakest link of whole of the implant design, right? So the delayed loading, we have to make the two-piece implant, and because the two-piece implant, we have to make the cylindrical design. Why? Because we had to accommodate this abutment inside the implant, right? This has to go inside the implant. That is why the implant was huge over here. The size was very great. So that is why we have to make a U shape or a cylindrical shape implant to accommodate the abutment inside the implant. Now, because of this U shape, what was happening is the bone after healing is usually presented to us in a knife edge ridge. right? So the bone shape is something like this, and we want to place an implant that is something like this. So what was happening is there was exposure of threads on these sides, and these threads has to be covered with the bone graft. And because the bone grafting is a very unpredictable process, it is very unpredictable, right? And it frequently resolves on itself, leading to peri-implantitis and implant failure. So despite all these efforts that we put in placing these conventional implants, still there is the problem of delayed loading, complicated prosthetic procedure. We have to do the open flap surgery, and still the unpredictability is there. Implant is very fragile because of the U-shaped design, the cylindrical design, and the abutment going inside the implant. The walls over here are quite narrow. The walls over here are quite narrow. So there is always a chance of peri-implantitis, screw fracture, or implant fracture anytime during the functional life of the implant. And also the bone grafting, right? Also the bone grafting is there. Here we can see the implants, some implants are failing. These are because of the peri-implantitis. Here also we can see because of the bone graft did not get accepted, right? It's a bone grafting failure. Bone grafting failure. The bone graft here failed. Implant osseointegrated, but bone graft failed. So this ultimately led to the failure of the implant. Here we can see the implant has fractured. Here we can see the neck of the implant has fractured. So all these problems are here. And what about the cases that we have to refuse, like extreme ridge atrophy, medical reasons such as diabetes mellitus, smokers, we have to refuse the implants. If the insufficient bone is there, we have to refuse the implants. If the bone is, if there are any bone defects, we have to refuse the implant. And in case of active periodontal disease, we have to refuse the implant, right? So all these cases can also be considered as the failures because we were not able to do the implant over here. So these are the failures of the two-piece implant because we have to refuse these cases. So what if I present to you an implant system that can be loaded within 72 hours? Additionally, can be done in any case. That is, you don't have to refuse any case, no refusal. There is no bone grafting, no membranes, can be done in smokers and diabetics, have no risk of peri-implantitis, and have no risk of fracture. Anyone interested in this system? So this system is the Bonanker implant system. So we have three implants in the Bonanker implant system. One is the Tornado B, one is the Tornado W, and one is the Tornado BW. Right? So Tornado B is a fully surface treated design. These are the rough surface compressive implants. Whereas Tornado W is the smooth surface compressive implant. And the Tornado BW has the rough surface only on the middle third of all the threads. The threads above it are smooth, the threads on the apex are smooth. In between the third, one third of the threads are rough. So these are the Tornado BW implants. Now let us consider about the implant morphology. It's a single, as you can see, these are single piece or monoblock constructions. Hence, there is no chance of implant fracture. There is no chance of screw fracture. These have a cementable abutment. That is, you can give a normal PFM crown over it. The prosthetic procedure is very simple. prosthesis with GIC over the implant, nothing else. We have a tapered implant body. The implant has a tapered profile. So what advantage does it gives? It gives us the high placement torque, immediate high primary stability, better intraosseous stress distribution is there. Apart from that, there is the narrow shaft. The shaft diameter is only 2 millimeter. So what advantages does it gives? It gives us the advantage of inbuilt platform switching. Apart from that, it gives us the advantage of reduced emergence profile because only a 2 millimeter neck is coming out from the gingiva. So the gingiva is very happy with the implant, right? And also it has the RBM, or it is also known as the SLA surface, right? The W implant has a smooth surface. The Tornado B implant has a surface treated SLA surface. And the Tornado BW has the middle third part surface treated with the SLA coating, right? So the available sizes in these implants are the diameter available with us are 3 millimeters, 3.5 millimeters, 4 millimeters, and 4.5 millimeters, and 5 millimeters is there. So these are the diameters that are available with us. Apart from that, we have length from 10 millimeter, 12 millimeter, 14, 17, 20, 23, 26, and 29. So these are the lengths that are available in these diameters, right? And the design characteristics are in the Tornado W, we have the completely smooth surface implant. In the Tornado B, we have thread that are surface treated. This part is surface treated. And in the Tornado BW, we have the middle third part surface treated. Right? Any confusion still now? Anyone wants to ask a question? Anyone wants to ask a question? Dr. Sebastian? Dr. Sebastian? Dr. Jashri?
Yes.
Any questions?
No, no, no.
Dr. Piyush, any questions till now?
समझ में आ गया.
No, sir. No, sir.
Okay. So you got the point. This is the Tornado W, the whole white part, right? So that white stand for W stand for white, B stand for the black, right? It's surface treated, and BW stand for the partially surface treated implants, right? So we have made a very easy nomenclature for everyone to remember. So the implant name is the Tornado implant. So another important notice, like if anyone is, I want to ask a question. Is anyone scared of using a single piece implant? Is there any doubts about using a single piece implant? I am asking everyone from the group. Does anyone do implant over here? Dr. Sebastian, Dr. Orlando, Dr. Victor Manuel, Dr. Carlos, Dr. Eugenio. Everyone does implants over here, or you are starting for the first time? You can write in the comment box too if you want to. Okay, Dr. Orlando does the implants, right? So you use two-piece implants or one-piece implant? Both, but more one piece. Right. Right. Monophasic. You call them monophasic. Yeah, that's a nice word. In our part of the world, we call them monoblock. So even the other companies that were earlier related to two-piece implant are bringing very frequently, they are shifting towards a one-piece design. Here you can see an implant developed by the Noble Biocare, in which what they have done is they have made the implant in a single piece over here. So there is a multi-unit that comes pre-attached with the implant itself. It's a transmucosal implant, and here you can either attach the cover screw if you want to healing abutment, or you can directly place the abutment over here and cement or give the cement retained prosthesis over the implant. And even the other company, there is also a monophasic implant, like we are talking about the monoblock implant that is known as the Noble Direct. Even the Ostium have bring up their MS implant range, that is single piece implant, and Norris is also bringing us a single piece implant profile, right? So the single piece implants are coming out very good. So if there are people that are concerned about using they are using a two piece implant and they are not very sure about using a single piece implant, so let me tell you, the future is the single piece implant. The future is going to be this system, a single piece implant system, right? So we shall now begin. So what inspired the design of the tornado system? So we derived the design from the orthopedics, right? So basically what happens is, in orthopedic surgery, the principles of fracture treatment emphasize on immediate splinting and loading to minimize multiple surgical intervention. Like in dentistry, in two-piece implant, we do the delayed loading. So there are two surgical procedures for replacing a tooth, whereas in orthopedics they prefer using doing the procedure in a single go. Second stage surgery under total anesthesia adds the risk cost, reinforcing the need of immediate functionality, right? And there are certain complications in the second stage surgery, like osteomyelitis and excessive post-operative swelling. Whereas in dental implantology, what was happening is our reliance on healing time and secondary procedures increased over time, which increased the overall treatment time, the patient discomfort, and the financial burden on the patients, right? Two-piece implants are a remnant of conventional dental implantology, suffer from a weak structural integrity, and increases the chance of micro movements leading to the implant failure. The connection between the two pieces of the implant create a biological micro leakage risk, potentially leading to the peri-implantitis and other long-term complications. Immediate loading is challenging with two-piece implant due to their inherent instability and delayed osseointegration. So the role of Bonanker implant system in these things. So what we did is we conducted a huge research and we integrated the principles of orthopedic into dental implantology, right? We studied, we are basically an orthopedic parent company. So, and we hold more than 20 patents in orthopedic and dentistry combined. So what we did is we brought the knowledge from orthopedic into the dentistry and emphasize on immediate functional loading. We eliminated the need for extensive bone augmentation, reducing the surgical interventions and the recovery time. We also offer a very cost effective, accessible treatment alternative to complex implant solution. And all the system that we have designed aligns with the philosophy of orthopedic fracture treatment, one time surgery, immediate loading, and optimal long term bone health. So these are all the principles that are being followed in the implant system. So, first of all, we must understand what are the types of anchorages in the orthopedic, right? In the conventional implantology, we are concerned about only using the alveolar bone. Suppose this is the alveolar bone, and we have placed the implant over here. right? So this type of anchorage using only the alveolar bone is known as the mid body anchorage in the orthopedics. Apart from that, there are two other means to anchor the implant inside the bone. One is the transcortical or the bicortical route. That is, our implant exits and take anchorage from the basal bone or the secondary cortex. So that these are known as the transcortical or bicortical anchorage. And one is we can rest the apex of the implant on the basal cortex, right, on the secondary cortex. So these are called as the pericortical anchorage. Similarly, in dentistry, as we can see in this diagram, all these are mid-body anchorage implants, right? These are only taking anchorage from the mid-body, whereas these implants are resting on the secondary cortex. So these are known as the pericortical implant. The side implants are the mid-body implants. The implant that are resting on the basal cortex are the pericortical implants. And if we perforate and take anchorage from the secondary cortex, then these are known as the transcortical implant. That is, the implant is exiting from the secondary cortex. Any questions till now? Any questions till now?
No.
My tabletop is visible to everyone? Yes. So we were talking about the three types of anchorages in the dental implants. One is the mid body. Second is the pericortical. Third is the transcortical, right? So in the conventional implantology, what we do is, suppose this is the bone. We are taking the example of a mandible over here, right? In the interforamina region we are talking about. So what happens is, suppose we have to place an implant over here, right? So what we can do is we can place an implant like this, like we place an conventional implant, right? So this kind of anchorage is known as the mid body anchorage. And if we go in a little deeper and we go till the base of the mandible over here, right? And we rest the implant such that the apex of the implant is at the basal cortical. So this now, my friends, is called a pericortical anchorage. And suppose what I do is I perforate this cortex. I perforate this cortex with the drill, and then my implant goes through this cortex. Now this is called as, anyone wants to answer? What will be this called? This kind of anchorage, what
Bicortical.
will it be called? What's a
Transcortical. Transcortical.
transcortical? Transcortical. So this is the transcortical anchorage, right? So it's clear to everyone. Any doubts till now?
No, sir, it's clear.
So if I do the osteotomy and I only go till half the depth, like I only go this much in, so this will be the mid body. If I go whole the way down, then it will be known as the pericortical. If my drill exits, if my drill exits from the base, if my drill exits from the base, and I place the implant such that it is coming out from the base of the mandible, then it will be the transcortical anchorage. So this is the concept. So what are the principles of permanent biological integration of these implants? How do these implant, the tornado implant, functions? So number one is the induced corticalization, right? So basically what happens is, everyone, am I clear? My voice is clear now? Everyone is able to understand? Dr. Victor, Dr. Orlando, Dr. Jose, Dr.
Yes,
Raul?
sir. Yes, sir.
Okay, clear, all clear, right. So I am again shifting to my tabletop.
I'm
I
here.
will, you like the presentation or you like the tabletop better? You like the chalk and talk method or you like the presentation better? So basically what happens is these are immediate loading implants, right? So the immediate loading implant always relies on minimum two processes for integration, right? From the time of implant placement till the osseointegration happens, that is during the healing phase. We need an other kind of anchorage to support the implant. After the healing phase is over, from 3 to 6 months, the osseointegration takes place, right? So then our implants rely on the osseointegration. But what about these 3 to 6 months? How will be the implant supported in this time? So for the mid body and the pericortical implants, right? For those, both these implants, the process that helps the implant in this period is known as the induced corticalization. Okay, induced corticalization. So in the initial phase of the implant healing, that is from the time of placement till the osseointegration takes place, it is done through induced corticalization, or aka it is also known as the osteodensification. In the late phase, that is throughout the functional life of the implant, it is through osseointegration. So what is the induced corticalization or osteodensification? So it's a very simple process. So what happens is, because it's an attribute of an underprepared osteotomy and a tapered implant geometry that compacts and densifies the cancellous bone and enhances the cortical characteristics. So what happens is, we do a narrow osteotomy. We do a narrow osteotomy over here, and then we place a wide implant over here. So what happens is, the bone around the implant, it densifies, right? It densifies. So that process is known as the induced corticalization, right? So what happens is, suppose this is our bone. This is the cortical bone, and in between it's the soft spongy cancellous bone, right? So what we will do is, we will do a narrow osteotomy over here, only with the 1.8 mm pilot drill. We do the osteotomy. Then we place a wider diameter implant in this side. So what will happen is, because of the wide diameter of the implant, the bone around the implant actually condenses. It compacts the bone around the implant. So there will be a dense bone formed around the implant. Okay, so this dense bone, it will support the implant. It will support the implant in the healing period, right? That is from the 3 to 6 months period. This process, the induced corticulation, the hard bone, will give the anchorage and stability to the implant. Later on, what will happen is the osseointegration will take place. Right? Clear? So this is for the mid body and the pericortical. That is the implant that are resting on the basal cortical. For these implant, this is the process. That is the induced corticalization followed by the, am I clear? Osteofixation, right? But what about the transcortical implant? What about the transcortical implant? That is, this is suppose the first cortex, this is the second cortex, and my implant is going through the basal cortex. Okay, my implant is going through the secondary cortex. So now what happens is my implant also takes the anchorage. My implant is going through the bone, right? My implant is going through the basal bone. So it is also taking anchorage from this side, right? It is taking anchorage from this bone. So taking anchorage from the secondary cortex or the basal bone, in our terminology, it is known as the osteofixation, right? So what does the osteofixation do? It increases the primary stability of the implant. It gives us the high torque value, right? And it helps in preventing micro movements, right? So what advantage does it gives? It gives us the advantage that the implant osseointegrates early and it has a high stability. So there is a less chance of failure. Clear? Any doubts till now? All clear. Thank you, Dr. Orlando. Dr. Hector, thank you. Are you having any trouble in understanding my language? Right. Thank you. So from the initial period till the healing happens, either we use the induced corticalization or we use the induced corticalization plus the osteofixation. Here we can see the implant is osteofixated. right? The implant is taking anchorage from the basal cortical bone. So either the two or one we take the advantage of. Later on it is followed by the osseointegration. In both the cases osseointegration will happen, right? So now the implant selection, since we have three types of implants, right? So these all are the tornado implants. Everyone please write tornado in the comment box if you are understanding my presentation. Please write tornado in the comment box. Okay, nice, thank you. Right, thank you so much. So on the extreme left side, this implant is the tornado B. That is the surface treated design. The threads are all surface treated, are all rough surface. This is the tornado W, in which the threads are all smooth surface. This is the tornado BW. Okay, it's very easy to understand. The black B for stand for black, that is a surface treated. White W stands for white, that is a smooth surface, and BW stands for black and white, that is it has both. The middle third of the threads are rough surface. The threads near the shaft and the threads at the apex are all smooth surface, right? So how do we select the implant? And what is the size of the implant that we are going to select, both in terms of length as well as the diameter? So there are certain criteria that we need to take into consideration for implant selection. The basic criteria are, if the what is the type of the implant site, either it's a fresh extraction site or it's a healed site. Fresh extraction site is you immediately extract the teeth and you immediately place the implant in a single go. So that is termed as the fresh extraction site. From the period of extraction till the healing is complete, that is from 3 months. After 3 months of extraction, it is known as the healed site. And any time in between this is known as the intermediate site, right? Secondary, we depend upon the quantity of bone that is present. If sufficient bone is present, both in terms of height and width, and if insufficient bone is present either in terms of height or width or both, and then we have to consider the medical status of the patient, that is, if he is diabetic or not, if he or she is a smoker or not, if the socket is infected or not, and if there is any active periodontal infection or an active periapical infection. On these basis, we are going to select the implant. So once again, it's clear. Everyone is clear about the names of these implants.
Yes, Daksh.
Right. So basically now we have three types of implants. Right. I will draw these one by one. So one are the W, that is the completely a smooth surface implant, right? one is the B, that is the implant surface is surface treated, right? And then we have the BW, in which what happens is the middle third part is surface treated, right? So first we have to consider whether the site is healed or a fresh extraction site or it's intermediate. Fresh extraction site is on the day of the extraction, right? From here till 3 months, after 3 months, it is known as the healed site. And in between the time, in between the fresh extraction socket and the healed area is the intermediate, that is from 0 to 3 month. The 0th day, okay, till 3 months is the intermediate site. So for the healed area, for the healed site we are talking about, we have to consider if sufficient bone is present or not, right? If sufficient bone is present, bone both in terms of the width as well as in terms of the height, we go with the tornado B, that is the surface treated design, right? If it is a healed site with sufficient bone, patient is not diabetic, patient is not a smoker, okay, and there is no active infection, no infection, we go with the surface treated implant. And suppose if there is any complication, like the patient is a smoker or the patient is a diabetic, we use a smooth implant. Smooth implant plus pericortical or transcortical anchorage. This is very important in smokers and diabetic. You should do the implant as long as possible, either with the pericortical or with the transcortical. Like we studied now these implants. So in diabetics and in smokers, we don't do the mid body. We always try to go with the pericortical or the transcortical route, and we use the implant that is the smooth surface implant, that is the tornado W, right? Got it? And apart from that, if the site is extraction site, a fresh extraction site is there, right? In that case, we have to consider if there is a infection present or not, right? If there is not any infection, there is no infection, then we can use the tornado BW, that is the partially surface treated implant, right? And if there is an infection present, right, if there is an infection present, then we can use the tornado W, that is a smooth surface implant. Any problem still now? Any problem still now? Any doubts? Please ask. So what is the advantages of these three designs, right? So the advantages are our bone is in approximately in this shape, right? So whenever we place the implant, even if some threads are exposed, like I place the implant, and even if some threads are exposed, right? These threads are exposed. So because these are the smooth surface threads in this implant and this implant, so we are not really concerned about the bone grafting over here. So what will happen is the mucosa will grow over this part through the process known as the muco integration. Right? I will show you a case again. I will show you a case of mine. So here we can see there was a huge defect in the buccal plate. Everyone can see there is a huge defect in the buccal plate. So what I have done here is I have placed the BW Tornado BW implant over here. You can see in the CBCT that the implant threads are exposed, but I did not do any bone grafting over here. No bone grafting was done, and a temporary prosthesis, a PMMA prosthesis, was given. Okay, PMMA prosthesis was given. So after 6 months, when I wanted to replace the prosthesis, you can see the beautiful gingival healing over here. Right? No bone grafting was done. The soft tissue adhered to the implant surface. So this process is known as the muco integration. So that is the rationale behind these implants. Why we have developed these implants over here. Right? So what we want is if there is sufficient bone present and we can completely submerge the implant in, then you go with the surface treated implant. If there is any doubt that whole of the threads will go inside the bone, if you have any doubt that some threads might be exposed, then in that case you can go with the smooth surface implant or a BW implant over here. In that case, what is done is even if some threads are exposed, the soft tissue will grow over these threads because it's a smooth surface. So the soft tissue will grow and there is no chance of peri-implantitis with the smooth surface. In diabetic patients, in compromised sites, if patient is medically compromised, if there is any periodontal infection, if there is any kind of infection, what you can do is you can use this smooth surface implant. Right?
Es que me lo puse de este lado y no se escucha.
Any doubts, sir? Dr. Daniel?
No, sorry.
Dr. Daniel, any doubts?
No, sorry. My speak is on.
Nothing to worry, nothing to worry. So everyone understood how to select the implant? Got the point? So now we will see how to select the size of the basal implant, and also we will study the drilling protocol with that only, right? So I am going to shift to the tabletop now and we are going to study how to select the size of the implant. Any doubts till now? Any doubts?
No, doctor, it's good.
Sir, I'm not able to understand. You can please write in the comment box if you can. So while selecting the implant, there are two things to be selected. Three things, sorry. First is the type that we have done. Second is the length. Third is the diameter. Okay, the type we have already studied. Now we will study about the length of the implant. So the length can be selected in two ways. Number one, that is pre-surgically, and number two is during the surgery. Right? So pre-surgically, if we are going with the mid body, what we can do is we can select the length with an OPG or a CBCT, right? But if we are planning for pericortical or we are planning for the transcortical, the length will be determined during the surgery, right? Suppose if I am going to do a mandibular posterior, right? So I am going to do a mandibular posterior region. So I know where the level of the nerve is through the OPG, right? I know where is the level of the nerve is going, right? I know that with the OPG. So suppose this is the mandible, this is the mandible, and this is the nerve going through. So I want to keep a distance of approximately 2 millimeters from the implant's apex. I want to place an implant such that there is a 2 millimeter difference between the nerve and the implant, right? So I already know what is the length of the implant. And suppose I am going for a pericortical anchorage in the mandibular anterior region. So for now, what I have to do is I have to drill and I have to feel where I get the second resistance. Okay, when I reach the base, I will get a resistance over here. In that case, I will select the implant of the length of the implant during the surgery. Even in the transcortical, when I'm coming out, I will select the length of the implant during the surgery itself, right? So these things can be managed, right? Got the point? Everyone understood how to select the length of the implant? So the lengths that are available with us are 10, 12, 14, 17, 20, 23, 26, and 29. So that is why this huge selection of length is there, because if we want to reach the transcortical or the pericortical, then we have the sufficient length of implant are available with us. Is there any doubts? Everyone able to understand? Now, how do we select the diameter of the implant? How do we select the diameter of the implant? Diameter depends upon the density of the bone, right? So what I will do is, this is my first cortex, this is my second cortex. So length I have already pre-decided. So I will do is, at I will start the drilling with the pilot drill. That is the 1.8 mm drill, right? I will do the osteotomy with the pilot drill. Then I can get three conditions. Either the bone density can be hard, that is it can be D0 or D1. Bone density can be medium, that is D2, D3, or bone density can be soft, that is a D4, D5 type of bone, right? So when I have a very soft bone, I will do the pilot drill, then place the implant. Only single drill is to be done, and the implant diameter would be a 5 millimeter or a 4.5 millimeter implant. Okay. In case of medium bone, I will do the pilot drilling first of with a 1.8 mm pilot drill. Then what I will do is I will do the parallel drill of 2 millimeter till half the depth, till half the depth. I will do the second drill only till half, and the diameter that I will place will be a 4 or 4.5 mm. Right? In case of hard bone, I will do the pilot drill till full depth, pilot drill. Then I will do the parallel drill also till the full depth. And the implant that I will select will be a 3.5 mm implant. Clear, everyone?
Yes, it's clear.
So this is how we do it. This is a screenshot. Anyone wants to take a screenshot of this can take it. This is the drilling protocol, right? For a soft bone, only the pilot drill is to be used. Then no further drilling is required. No further drilling is required, and we directly place the implant. Implant is placed directly. And the diameter to be used is a 4.5 or a 5 millimeter. In case of medium bone, that is a D2 D3 bone, pilot drill till full depth that is required, then parallel drill only till halfway. Only the half length will be done with the parallel drill of 2 millimeters. And the implant that we are going to place would be a 4 or a 4.5. In case of very hard bone, we will do the pilot drill the full depth required when and do the parallel drill till the full depth of the osteotomy, and then place a 3.5 mm implant over here. Right? So now we will see a tabletop demonstration about how to deal with the ideal ridge and how to deal with the compromised ridge or extraction case. This is visible. This is my tabletop is visible.
Yes.
Nice, thank you. So what can be done over here is, just wait on a minute. So suppose I am going for a mid body implant, right? So I have pre-selected that I will place. Anyone wants to ask a question? Someone has raised their hands. You can unmute your mic and ask the question. Anyone? No. Okay. Suppose I have predetermined the length of the implant, right? So what I will do is I will do the crestal osteotomy over here. This I am doing in case of a healed site, right? And I am going to select a surface treated implant. That is the Tornado. Anyone wants to answer the question? What is the name of the implant? The rough surface implant, that is a Tornado B. Okay. So I will place the implant over here in the prepared osteotomy. Right? In case of when I can submerge all the threads within I will use a surface treated implant that is a Tornado B. And I can also bend the implant, right? I will demonstrate bending of the implant later on, right? So this implant can also be bent. But what about when there is an extraction socket with the huge buckle defect, like it is over here? Then in this case, what shall I do? What I will do is I will use the smooth surface implant or a BW implant over here. I will go till the I'll reperforate the basal cortex, right? My drill has exited. Now I will take the transcortical anchorage and I will select the length of the implant accordingly. As we can see, these threads are smooth surface threads. Okay, then I will place the implant in this osteotomy directly in a pericortical or a transcortical anchorage, and I am not concerned about these threads being exposed. These threads will eventually be covered by the soft tissue, like the case I have shown you. The soft tissue will grow over these threads through a process called muco-integration, right? So in this way I can use the Tornado BW or a Tornado W implant in this site, right? Everyone got the point? Any doubts?
No, doctor.
Okay, thank you. I have shown you how to do it in an extraction site also. Okay, but basically we are more concerned about the main concern that we have in our case is selecting the type of the implant. So main thing is selecting the type of the implant. If you select the proper type of implant, now you will have no trouble because we don't need any kind of bone grafting for these implants. Here we can see the case I have shown you in the previously also. There was a huge buccal defect present and I chose the BW implant, that is a partially surface treated implant. All the threads that are exposed are the smooth surface threads over here. Only smooth surface threads are here exposed. So what happened is I gave a temporary PMMA prosthesis. I gave a temporary PMMA prosthesis. After 6 months, I removed the prosthesis for placing a zirconia crown. And here you can see how beautifully it has healed. The gingiva you can see has totally adhered to the implant surface. There is no kind of discrepancy seen, no exposed threads can be seen because of the surface of the titanium, because we use a grade 4 titanium in our implant. So grade 4 titanium is the best kind of titanium for the soft tissue to integrate with. Similarly, in this case also, I did an immediate extraction implant and there was a kind of knife edge ridge was present. There was a thin buccal plate was there. A thin buccal plate was there. Here you can see a thin buccal plate is there, but there was a problem with the lingual aspect. Okay, there was a problem with the lingual aspect over here. So what I have done is I have placed a Tornado BW implant. So on this side, on the buccal side, all the threads are covered with the labial plate, but on the lingual side the threads did not have a chance to being covered with the bone. So in that case I have used this kind of implant. So what has happened is only the smooth part of the implant is exposed to the soft tissue, and the soft tissue will grow over this implant surface and there will muco integration will happen. This was a case I have done with the pericortical anchorage. So I had enough bone that was present both in the width and the height. So in that case what I have done, I have used a fully surface treated implant for my case. in a pericortical manner. As you can see, the apex of the implant is lying on the basal bone. And in this case, I did an extraction socket. So the labial plate was present, though it was present, but as we all know, it is very prone to resorption. It can resorb anytime, right? So what I have done is I have planned in advance and I have placed the implant with the smooth surface threads near the shaft, right? So what's the advantage that I have over here? The advantage is even if the bone is resorbed, the soft tissue will still integrate over the smooth surface threads. Any questions, anyone? Any questions? Any questions, sir?
No, doctor, it's clear.
It's clear. You want to see the bending of the implant?
Yes, please.
Or I will use a very buccal osteotomy for your Vona. I will do a very high angle implant. So here I am placing the implant at a very high angle. So that is this is the maximum angle that we can face when treating the maxilla. Everyone can appreciate what is the angle of the implant. It is more than 45 degrees, right? Everyone can see it is more than 45 degrees, right? Now I will bend the implant. See how much bending have I done. So the bendability of our implant is the best in the industry. It's the most bendable implant in whole of the industry. You can bend it from 45 to 50 degrees max. Everyone can appreciate the bending of the implant. Anyone want to add something? You like the bending of the implant?
Yes, doctor. It's clear and it's very, very easy.
Very easy, right? So that is why we don't have to use any prosthetic component for the implant. You can place the implant in anywhere the bone is available. You place the implant, then you bend the implant to bring it in the prosthetically ideal position, right? So I also want to do an announcement. Is there any other question? So I do these kind of courses online also, in which you can register with us. And what we will do is we will send you these kind of model, the whole drilling kit along with the driver and implants. and I will guide you online through the various surgical protocols in the anterior maxilla, the posterior maxilla, including the pterygoid implant will also be covered, right? And everything I will demonstrate to you, and you can do it on your own models with me live, and you can show it to me with your cameras that you can connect with me, right? And if there is any corrections that is required, I will guide you through that. So this is basically a live hands-on training from the comfort of your own home, right? If anyone wants to join the training course or know more about the implant, they can connect with me on this number. They can WhatsApp me or email me. You can take the screenshot of this slide. Okay, this is my number. You can connect with me via WhatsApp or via email, and this is the number of the our sales representatives. You can connect with them if you want to order the implants. If you want to order a sample of the implants, we also deliver the samples of the implants, right? So if you want to order some samples, you can connect with them. If you want to order the implants, you can connect with them. And if you want to join the course, you can connect on these numbers also, right? Please take a screenshot. Any question, anyone?
सर लोअर पोस्टीरियर्स में इमीडिएट एक्सट्रैक्शन
Mm-hmm.
उसमें इम्प्लांट प्लेस कैसे करेंगे?
Sir, अभी maxilla का this is
Okay, okay,
today's topic is about the anterior teeth, okay?
okay,
And I am going to conduct a next webinar that will be a paid webinar about the posterior mandible. So
okay,
I will be demonstrating the lingual cortical engagement, the buccal cortical engagement, the nerve bypass, both lingual and buccal in the areas of premolars and molars. And I have also developed a technique for the first molar, right? Because nerve bypass is very tricky in the first molars. So I have also developed a technique for doing the nerve bypass in the first molars with these tornado implants, right? So you
okay,
can connect with me. You can register your number with our sales rep. You can contact on these numbers, and we
okay,
will discuss it too.
okay, sir. Thank you.
Any other question? Any questions, anyone? Dr. Raul, Dr. Victor, Dr. Rolando?
No, it's clear, doctor. All clear.
Anyone wants to order the implants?
This okay, doctor?
You like the implant system?
Yes, it's very easy and intuitive.
Very easy and intuitive. Right. Perfect word. Perfect word. Thank you for it. We will also use it in the marketing. Easy and intuitive. Anyone wants to add something? I really want if everyone can give me a short video testimonial and send it to one of these numbers. Everyone can do that with for me, please. Dr. Rolando, please take the screenshot of the slide that is present on your screen, okay? And make a short video testimonial, 10, 20, 30 seconds up to a minute, and please send it to us, everyone. I really request you all. So that will be very helpful for me. Thank you, Dr. Rahul. Thank you. I really want that you give me a video testimonial for attending my lecture, and that will be really helpful for me. Okay? Dr. Carlos,
Okay.
Dr. Allen, Dr. Piyush,
Okay, sir.
Dr. Krishna,
Yes, sir, we'll do that.
Dr. Eduardo, everyone, please send me a video testimonial, right? And thank you all for joining. Any other questions? No? Shall we end the meet now? Thank you, Dr. Rolando. Thank you. Thank you. Thank you for your kind words. Okay, everyone, then. I,
Thank you, doctor.
thank you.
Thank you,
Thank you so
doctor.
much for joining. Please send me a video testimonial, please. Okay, everyone. Thank you. Thank you for joining. Bye. Take care.
Thank
Have a
you.
nice day. Enjoy your Sunday, huh?